Good afternoon, Dr. Stout. Thanks for being here. I'm just letting you know I'm gonna share a little EA PowerPoint first and get us started here in a couple minutes, and then I'm gonna go ahead and toss it back over to you for your presentation.
Sounds good.
All right, sweet. Thank you.
Good morning, Dr. Stout. I'm Lisa Sopko. I'm actually the manager of community programming at the Epilepsy Association. So I started last May. So I'm relatively new, but I did want to introduce myself before we started. So it is nice to meet you, sort of.
Nice to meet you as well.
And we'll give it a couple minutes. So Bethany, let me know. You want to wait a few minutes?
Yeah, we'll give it until 3 o'clock, and then we'll go ahead and get started.
Okay, no, okay, gotcha.
You can go ahead whenever you're ready, Lisa.
Okay. All right. Well, good afternoon, everyone. Welcome. My name is Lisa Stopko. I'm the manager of community programming at the Epilepsy Association. I'm pleased to welcome you to our May Epilepsy Education webinar, and I'm glad you can join us for this online presentation. Thank you to our speaker sponsors, SK Life Science and Akron Children's Hospital. Their generous support has helped us underwrite the cost of hosting today's program. Please visit our sponsors' websites or contact the local rep directly. And this information will be shared in a post-webinar email. Just a few housekeeping items before we get started. Please make sure your computer, microphone, or phones are muted as this program is being recorded. Today's program will be about 60 minutes, including a brief Q&A session at the end. If you do have a question, please use the chat feature in the bottom right corner of the Zoom page. We will get to those questions at the end. And the recorded webinar will be posted on our YouTube channel to view later, as are our previous ones as well. So today, I'm honored to introduce today's speaker, Dr. Michael Stout from University Hospitals. He will be presenting on neuromodulation and epilepsy. And I would like to turn the program over to Dr. Stout to present on this important topic. So welcome, Dr. Stout, and I guess we're ready to go.
Thank you very much, Lisa.
Absolutely.
Thank you for the introduction. Thank you for the kind opportunity to speak. My name is Michael Stout. I am a neurosurgeon at University Hospitals, the director of epilepsy surgery. It's my pleasure to talk to you today about neuromodulation and epilepsy, which is both a new and old field of study that's kind of experiencing a resurgence and a lot of innovation going on in this what used to be very niche in epilepsy. So to kind of give a basic overview, when we talk about approaches to treat seizures, we pretty much put them into two different buckets. The first bucket is probably what most people are familiar with, and that's what we call more of a destructive bucket. Destructive has a strange connotation there, but it basically means something that we go in and we take out a piece of the brain, such as a resection. That might be something like a temporal lobectomy. We can do ablation, and that's with a laser or radio frequency. And we can do disconnection procedures, and that's maybe when we're going to take out, or sorry, more to disconnect larger areas of the brain where we don't want to take out large pieces of the brain. Now, the cousin to that is modulation. We can't remove or burn every part of the brain that causes epilepsy because there's many parts of the brain that are eloquent and serve an important purpose, or the seizures might be coming from multiple places or might be generalized, meaning there's no target to remove or burn. And that's where we get into the concept of modulation. And we'll get into kind of what these two concepts are, the open and the closed loop, as we go along. So, what is neuromodulation in general? So, it's the modification or alteration of nervous system activity by delivering either electricity or chemicals. And this can be delivered to the brain, the spinal cord, or the peripheral nerves. Most neuromodulation is electrical in nature. When we do think of pharmacological modulation, this is more with intrathecal therapy. If you ever heard of somebody having a pain pump or a baclofen pump with spasticity, that's also neuromodulation. But for epilepsy and for most applications, it's almost all electrical in nature. And so it's also important to break it down into there are both intracranial and extracranial techniques. So intracranial meaning in the brain, and extracranial meaning outside the brain. Um, Intracranial is when we actually implant something. So that is a device such as a deep brain stimulator, a responsive neurostimulator. Um, and then extracranial being vagus nerve stimulation, which kind of goes along both. It's an invasive procedure, but it's not in the brain, it's on a cranial nerve. And the true extracranial techniques are those which are transcranial magnetic stimulation. So most people in epilepsy are probably not familiar with these techniques per se. A lot of these are used for acute migraine attacks. There's some burgeoning evidence for depression. There is some application in the pre-surgical workup of epilepsy, but generally extracranial techniques are not thought to be techniques that we use on a regular basis to treat epilepsy. But in general, you're seeing these buckets. It's basically, is it invasive or is it non-invasive? And then is it in the brain or is it not in the brain? So why would we even consider neuromodulation in epilepsy? And I kind of alluded to this earlier. So already we know that a third of patients with epilepsy are resistant to medications. Many patients will respond to one medication, and then you have a ladder where you add that second, maybe even the third, some patients even more than that. The challenge with adding additional medications is that after that first medication, you have less success in terms of being seizure-free. You may still have seizure reduction, but you could still have breakthrough disabling seizures. And patients with epilepsy, the seizure burden is obviously subjective and it's dependent on how much it impacts your life. Somebody who's having a seizure a couple times a year might not perceive the same burden as somebody who's having a couple seizures per week. And then when we talk about people who are medically refractory or drug resistant, only a minority will be a candidate for surgical resection. So the best patients that we can see typically that are candidates for surgery are with people with mesial temporal sclerosis. So they have that specific scarring in their temporal lobe, and those patients typically present in a very specific way. And we can take out somebody's temporal lobe and offer a very high likelihood of being completely seizure-free off medications, north of 70%. But the problem is that's a very specific subset of people with epilepsy. So therefore, we have these patients that could be surgical candidates in other ways, or might not be those resective or ablative candidates at all. And so for those patients, that's when we start thinking about neuromodulation. Now, in medicine, when we say a palliative treatment option, that's not typically what people understand as a palliation. They might think of towards end of life. When we say palliative, we typically mean not with an intent to cure epilepsy. Um, so an important thing to think about as I give this talk, and you'll see some of the data as I go through it, is that neuromodulation modalities, when we implant them, is often not with the goal to cure some of epilepsy. Certainly, we have seen it, but often it's not. That's not the likelihood. So I'm going to show you a couple busy slides, but I'm hoping to kind of simplify them and break it down. This is a very kind of basic decision algorithm. Obviously, the decision making in epilepsy to go to surgery is much more complex than that. And this is obviously a little bit older, but the idea is still relevant. So if you have resistant epilepsy and you have generalized epilepsy, you are never a surgical candidate for a resective or ablative surgery. Typically, in the past, we would think those patients might go for a vagal nerve stimulator. These days, we're seeing more and more use of deep brain and responsive neurostimulation, which I'll get into. If you have focal epilepsy, meaning it's coming from one location, and you can localize that well, if you're following the bottom part of this graph, it depends, well, where is it localized to? Is it a place that is what we call eloquent or non-eloquent? Non-eloquent meaning a part of the brain that we can take, and there's either no risk or an acceptable risk to something like memory or another deficit. Those patients are surgical candidates. What I really want to highlight is look how many parts of this decision tree end up in neuromodulation, but not surgery. And that kind of speaks to the fact that as we know, epilepsy can be very complex. We do always want those patients that have very localizable, non-eloquent epilepsy, but that's not the reality most of the time. So we have to be able to offer something that can theoretically reduce the likelihood of seizures and improve people's quality of life. Now, this is the one slide. Don't even worry about trying to figure this one out. I'm not going to go too deep into it. The whole point of this is epilepsy is very complex. Obviously, we know that. And this is the interplay. This is a very basic idea of interplay in the brain, what we try to modulate. And this network, these networks, they have interplay with other networks. They go to places that control emotion, cognition, motor, sensation. There's overlapping targets here, especially kind of when you get to the middle part of the brain, the thalamus, which is the middle part of this image. So the point being is that research has been done for decades and decades trying to figure out the circuitry of epilepsy. And what modern neuromodulation techniques are trying to do is figure out, well, where in this circuit can we disrupt the propagation of seizures and improve somebody's quality of life? And you can see it's not always a simple discussion or a simple decision about which technology necessarily works in which patient. And a lot of the innovation we're seeing these days in the neuromodulation space is having a better idea of what can we target for specific types of epilepsy. So it's important to know that these devices have gone through rigorous approval, rigorous study. To be FDA approved, you have to run a randomized controlled trial. What that means is that you have to be able to compare the device to medical management and make sure that it is non-inferior, not causing any destruction or damage, and to see if the clinical benefit might actually be superior to medical management. And so these are the three devices that we use that I talked about earlier. So VNS, vagal nerve stimulation, RNS, responsive neurostimulation, and DBS, deep brain stimulation. All are stimulators, all act via different mechanisms. These are when the devices were FDA approved. And so you can see that for some of them, especially VNS, we've been using for more than 2 decades at this point. So we understand a lot um, about its applications. Things like RNS and DBS have only been around for a decade or so. And so we're learning a lot more about what the potential applications and efficacy of these devices are. But these are the three devices, the implantable devices that are approved currently for the treatment of epilepsy. So we'll start with the most common, vagus nerve stimulation. Just to kind of give you a brief overview, vagus nerve stimulation has been a known thing for over 100 years. And it's been a known it has a known influence on epilepsy for, again, almost 100 years. So this is something that has been developed kind of from the ground up and was the first implantable neuromodulation therapy to treat epilepsies. And you can see that the first implanted human was in 1988. And as I mentioned, you can see at the bottom of that slide, 1997 was the first approval. It is approved, and it's the only device that's currently approved in children down to the age of 4. Um, you'll hear me talk about labeling and the FDA indication. What we talk about is something being on label, meaning it's been studied for specific application. But we often use devices in what we call off-label fashion. We can implant them um, in patients with epilepsy that might not have gone through that RCT, that randomized controlled trial. We might have data through, I wouldn't say anecdotal, but case series, meaning people have published on series of 10, 20, 100 patients, and we know that there's something there, but they still need to have further study, more rigorous study to reach that on-label application. So, like I said, VNS first on label. It's indicated for children down to the age of 4. Even though it's the one that's been around the longest, and we've known vagal nerve stimulation for about 100 years, the mechanism is still somewhat unknown. Those of you may have heard vagal nerve stimulation also being used for things like stroke recovery, for rheumatoid arthritis, and these are also FDA approved applications. They operate a little bit differently than VNS for epilepsy, but it's interesting to see the potential applications of VNS in general. One of those reasons being is because the vagus nerve has such broad innervation throughout the body that there's so much, let's say, traffic that has to go through it to the brain. The way VNS for epilepsy works is, as you see here, you're delivering it kind of in like bursts, typically every several minutes for 30 to 60 seconds at a time. And the idea being is that you're desynchronizing the epileptiform activity. Vagal nerve stimulation surgery is very straightforward. So this is not brain surgery. It's invasive. It's targeting a cranial nerve, but it's not brain surgery. This typically takes anywhere from an hour to an hour and a half on average. It requires 2 incisions. You have one incision at the neck, as you can see in the upper left, and you have another incision either below the clavicle or in the mid-axilla region, typically depending on the patient's age and how much tissue they have. We find the vagus nerve, and you can see that's a middle picture right there. And the electrode itself is actually it's multiple coils, and we take those coils and we unfurl them, and then we wrap them around the vagus nerve. Um, and then you have a battery or a generator that goes into that pocket beneath the clavicle. Patients go home the same day. Typically, we don't turn it on right away. We let patients recover, and then with their epileptologist or their neurologist, they start the programming within 4 to 6 weeks, I would say, is most typical. So the vagus nerve stimulation, the implanted hardware, is that battery, is that electrode. And then on the outside, we have the programmer that the device representatives will have, and presumably your neurologist or epileptologist will, and they're able to change the settings. And then in the bottom picture there, you see the magnet, the swipeable magnets. And that's also given to all the patients. And you can actually give yourself a jolt of like a jolt of activity if you go over the magnet. If you feel a seizure coming on, it can give you stimulation. So when we talk about response, and remember that all the way back I talked about palliation as opposed to cure. So the responder rate, when I say responder, it's typically means to be a 50% improvement in whatever. So it could be 50% in pain, but here it's 50% seizure reduction. So the responder rate is about 40 to 50%. When we look at data, typically these patients tend to get better over time. So we see an increase in efficacy over time. There's a ramp up period. And it's around that 1 to 2 year mark that people typically plateau and how good they will get with vagus nerve stimulation. Historically, when we look at patients that respond well, it's pediatric patients, patients with generalized epilepsy, post-traumatic epilepsy, tuberous sclerosis. These typically are patients that might not necessarily be surgical candidates for resection or ablation. They have epilepsy that's less well defined. Generalized epilepsy is obviously coming from everywhere. And that's probably why the responder rates is relatively lower than surgery. But in some patients, a responder rate of up to 50%, meaning a 50% reduction, is actually quite good for quality of life. And with medications, it could be even higher than that. So it's all a question about what is the improvement in someone's quality of life? What are we looking to improve? So adverse reactions to vagal nerve stimulation are typically fairly benign. So incision site pain is typically from the surgery itself. The battery is relatively small. Patients don't often develop pocket pain or irritation at the battery. So it's usually limited to the surgery. What is very unique to vagus nerve stimulation is that you can actually have voice changes or hoarseness because the vagus nerve is right next to the voice box and interacts with the nerves that innervate that. And that is often stimulation dependent. So, what I mean by that is if the stimulation is too high and patients feel like a catch in their throat, that can result in the other two as well, throat pain and cough and hoarseness. So, that's something that you can work on with your neurologist, your epileptologist to bring the stimulation level down. So again, those last three are typically what we call stimulation-related adverse reactions and can be modified. Moving on to deep brain stimulation, many on this webinar might know brain stimulation as a component of treatment for movement disorders. So these are patients with Parkinson's disease or essential tremor. It's very popular to see videos out there of a patient that is shaking their hand and they turn on a device and the tremors go away. So again, deep brain stimulation is something that's been known about for decades and decades, is a well-established therapy. We liken it to the idea of a pacemaker. So what this is an electrode, two electrodes typically that go into the brain. You can see a little battery there in the lower right, the battery or the generator. And so that's the electrical signal that pushes it into the brain and acts kind of like a pacemaker. When we think about deep brain stimulation surgery for movement disorders, we often do these awake. And I'll get into that in a slide or two. But what's different here is for epilepsy, these are all performed asleep because in tremor, we like to see patients' tremor respond in the operating room. It's not a necessity, but we can do certain mapping paradigms where we see patients' tremor go away and make sure we're not getting side effects. But for epilepsy, these are almost universally done with the patient asleep. They don't need to wake up or do anything to cooperate with us. Getting back to that fairly complex circuitry that I showed you at the beginning, um, the way this works is that it targets the on-label targets is something called the anterior thalamic nucleus. That's straight in the center of that picture on the right. And the idea being is that you're disrupting or you're modulating these circuits. So you have a seizure that propagates and you're changing the pathways. You're changing its ability to kind of make it around that circuit. Um, and so the indication, the on-label indication, is a partial or focal seizure, which includes a secondarily generalized seizure. So something that starts from one area of the brain and might go to another and cause a generalized tonic-clonic seizure. The best evidence are for seizures that originates in the frontal or temporal lobes. And again, remember, I'm saying these on-label indications. There's interesting applications I'll talk about a little bit later that we're seeing even other parts of the thalamus. So people are implanting deep brain stimulators at different areas of the brain based on what patient's seizures might be like. So this is kind of getting back to that awake surgery. This is very classically patients with Parkinson's or tremor. So I will say that they're often not giving me the thumbs up when we put the frame on. The frame does have to be screwed into the skull. To be fair, we often give these patients some medications to help them relax. We certainly numb up the head all the way around. Why do we need to screw this frame into the skull? Well, this holds the head into place. So if you can imagine that we need to hit this small target in the brain, which is about, we have to be accurate to a millimeter. We don't want any shift. We don't want the head moving. We certainly don't want it moving while we're doing the drilling into the skull and things like that. And so then on the right, you see some of the typical testing. And that testing is, like I said, it's helping us to localize when we get the electrodes into the brain. Although MRIs are very good these days, sometimes it still helps to be able to have the patient cooperate with us. And this patient right here is doing a finger to nose testing. So, very commonly in tremor, patients will have a wavy finger, and that interferes with quality of life and things like feeding yourself, being able to write checks, to do anything with your hands. And it's very gratifying when you basically completely straighten that tremor out. The tremor goes away, and you can do that with the patient awake and comfortable. And that's very common for deep brain stimulation surgery for tremor. Now, for epilepsy, it's a little bit different. We don't need to do that type of testing because the target is the target in most senses of the word. And we don't need to do any specific testing because there's no testing to tell us that we're at what we call the thalamic nucleus. So when we do this surgery, this is typically how it looks. This is a very common frame that we use. This is called the Lexell frame. There's many ways to hold somebody's head nice and still, but this is probably the most ubiquitous. Um, what you see on the far right picture there, we're looking at the surgeon's view from the top, and that little cap right there is holding the electrode in place. And this is the general idea is that we put two electrodes in, and then we tunnel down into the chest to implant that battery. There are different manufacturers that make these devices. There are some somewhat subtle different ways to implant the devices, but in general, it's the same sort of idea. The electrodes go in, they're fixed to the skull, and they're tunneled to the chest. The way we do it for epilepsy and a lot of movement disorders these days, if we don't want to do them awake, is to do them asleep. So, what I was saying to you earlier is that, well, we'd like to see the tremor go away, but how do we know we're in the right spot if it's all done asleep? When we want to be accurate to the millimeter, we need some sort of confirmation. This is the way that I do it. Many other people do it as well. So this patient is asleep, and they're in a device that's similar. It's called the O-arm, and what this is, it's basically an intraoperative CT scanner, which takes an image, and we're able to merge that image compared to our preoperative plan. And once the electrodes are in there, we can actually make sure that the electrodes match our preoperative plan. So, image guidance or image confirmation is an important part of any intracranial surgery where we're putting electrodes in because we want to make sure things end up where they're supposed to be. Because if things are off target, we need to figure out how to get them on target and what made them off target to begin with. So, like I said, this is a very common way of confirming. This is the way that I do it. So a lot of my colleagues do too. There are some centers that will do this in the MRI scan. I also use a robot for my implantation. Basically, no one technique has been proven to be more accurate or more successful than another. They've all shown to be fairly equal. What's just important is that the surgeon that you work with is consistent in how he or she approaches their cases. So when we look at evidence, at the top there is that RCT. And this study was called SANTE. This was the anterior nucleus trial for DBS. And every kind of step down, that OLE is an open label extension. Basically, what that means, the RCT is the foundation of how these data are generated and how we get approval for these devices. But after the study is done, we don't just kind of wash our hands of it. We want to make sure that these patients are followed up. And what's great about these therapies is that they're followed up for many, many years. We want to make sure that these patients continue to do well. And kind of what I was alluding to earlier with vagal nerve stimulation is that over a long period of time, we also see a ramp up. People are doing better with a therapy after 1 or 2 years. And in this meta-analysis, it's showing you that the seizure reduction did approach 75% um, in the original study cohort. DBS is by nature more invasive than vagal nerve stimulation because we're going into the brain. I still like to tell my patients this, of all the things we do, is minimally invasive brain surgery. It's two electrodes that go into the brain. Often for epilepsy surgeries, we take out entire lobes of the brain. So this is, all things considered, minimally invasive, but there's still a risk by putting something into the brain. Main risks is hemorrhage or infection. These are very low risks. They're much less than 1%. And when I say hemorrhage, it can be hemorrhage along the tract of the electrode going in. Something that's catastrophic, and that might mean a large bleed, a big stroke, a life-ending bleed, is vanishingly rare. Much, much, much less than 1%. So these surgeries in general are very, very safe and effective. Often the risk of infection is not the electrode going into the brain, it's actually the battery itself, or sometimes the relay electrodes that connect the brain to the battery. And we deal with these in different ways if they do present. When we talk about paresthesias, that's numbness or tingling. And again, that's stimulation related. Depending on how robust the stimulation is when we turn it on in the brain and depending where the electrodes are, patients might get side effects. And one of the most common side effects is paresthesias or numbness and tingling that could be down your cheek, down your leg, down your arm. And that's something we just need to figure out in terms of how much currents do we actually drive through these systems. Same thing as VNS, there is incisional related pain, implant site related pain, which is typically transient. I put a giant asterisk here for neurocognitive side effects. When we implant DBS for movement disorders, commonly Parkinson's, because of what we're targeting, we do have to do a very thorough preoperative workup for patients that have depression and memory impairments. We haven't found that the same issues have been with patients with epilepsy. Um, Again, it's always better to have longer term data, which we do more so in patients with Parkinson's. But so far, the neurocognitive side effects for DBS in patients with epilepsy has not been a significant part. There have not been a significant a proportion of patients who have reported these. So we just got over the open loop systems. Open loop are devices which you put in, you set a specific stimulation threshold, and you can modify things like the current or the amplitude. You can modify the frequency, um, and you can modify something called a pulse width. And basically, what that is you're designing how much electricity you're putting into the brain. And the way we titrate that is kind of the adverse effects I was telling you about. So if someone has paresthesias from DBS, you turn it down. If somebody has the hoarseness and the tightness from the vagal nerve stimulation, same thing, you turn it down or you spread the stimulation out over longer intervals. We in neuromodulation, neurosurgery, neuroscience have been chasing after something called closing the loop for many, many years. A closed loop system basically means that you have a device which is able to read electrical activity in the brain and also deliver stimulation without input. So without the surgeons or the epileptologists or the neurologist input. We do have to set certain parameters for seizure detection threshold, but the whole idea is that a device, such as a responsive neurostimulator, can pick up the electrical activity in your brain and then deliver a burst of energy that dissipates the seizure from propagating. Um, so this is the responsive neurostimulator system. We've recently got into this in pain as well with some spinal cord stimulator systems, but closing the loop has been a big physiological step that we have been waiting to take, and now we're kind of getting into that era. So responsive neurostimulation is very interesting because of its potential applicability in many different scenarios. So a lot of those patients that I talked to you about earlier on, if you remember from that first blue flow chart, patients with two seizure foci, patients with bitemporal epilepsy, previously they would never be considered surgical candidates or even neuromodulation candidates, really. Or I wouldn't say that. It's more that we didn't think we had a good device for them. Now we can target specific areas of the brain. And good RNS indications are people with epilepsy in both temporal lobes. You can't take out both temporal lobes or you develop debilitating anterograde amnesia. You can take out one temporal lobe, often the non-dominant one, and dominant temporal surgery has to be very carefully selected. So bitemporal epilepsy is an excellent application for this. Um, when you have patients that have neocortical epilepsies with two foci, basically you have two different areas of the brain that are both epileptogenic. You can target both those at the same time. The unsafer sections are those in eloquent cortex. Eloquent cortex can mean a lot of different things. It can mean speech, it can mean motor function, it can mean sensory function. Now we don't necessarily have to remove them, we can modulate them. Um, an interesting application of this is also a diagnostic tool. When patients come in and have an inpatient's EMU admission, they might be there for a few days, ambulatory EEG, even invasive monitoring where patients might be in for 1, 2, 3 weeks at a time. That's still not a patient's entire life, obviously. You can see seize differently across a year than you might across 1 to 3 weeks, and certainly 48, 72 hours. So if you're having a device in there that's constantly reading your brain and sending those signals to your epileptologist over the course of the lifespan of the device, you might be able to see areas of your brain that could potentially be operated on at a later date that wasn't obvious earlier on. So I always show this case. This was actually my first SEG case I ever did while I was still practicing in Michigan. This was a patient with bitemporal epilepsy. This is the SEG planning. And this patient had very debilitating bitemporal epilepsy, and it was non-lesional, meaning there wasn't a part of the brain that necessarily looked um, abnormal. That would maybe give us a clue to one side or the other that we should be targeting. When the patient had a scalp EEG, they seized equally on both sides. So this is how we targeted the implantation for SEEG, which is that invasive diagnostic testing. So you can see there's many electrodes. I think there's about 21 in here targeting both sides. So both temporal lobes, part of the frontal lobe, and part of the insula on both sides, what we thought was the network for this patient's epilepsy. And the point I want to bring up here is the kind of the differential uh, what we saw over time in terms of where this patient's epilepsy developed from. And you can see that in the upper right and lower right, you're seeing kind of a breakdown of now we're seeing epilepsy from the right hippocampus being 73% of the time, and the left is 27% of the time. And then over a year, it eventually became 90% and 10% from the right side. So this is a patient that we're like, you know what? It makes a lot of sense given the fact that they're seizing mostly from one side that we actually take out the right temporal lobe. And I'll show you a picture in a second. And so when we used to think of patients that a bitemporal epilepsy was not a surgical patient, RNS in this patient actually showed us the error of our ways. And so this is the original surgery, putting the RNS in. What's unique about RNS is that we actually put the battery in the skull. And so as opposed to the previous the DBS where we put the battery in the chest and the VNS where we put the battery in the chest, this goes in the skull itself. We drill off a small like oval shaped cranial plates. We're not actually looking at the brain. What you're seeing in that top right picture is actually the dura. So the bone's taken away and it's the cover of the brain. So it's not the brain itself. Um, and then we place this clamp basically inside that skull defect, and the battery goes inside of that. And you're seeing that in the bottom middle part of the picture there. Um, and then obviously the electrodes go directly into the brain, and then they're looped in that incision to be very localized in the scalp. And this is what a postoperative X-ray looks like. So you're seeing that kind of the curvature of that battery. You're seeing the electrode wires. This patient had two electrodes into their hippocampus on both sides, both temporal lobes, and they had an insular electrode too. And it's important to note that this device only implants two electrodes at a time and will be for the foreseeable future. So you have to be pretty judicious about what you're implanting. So the question is, well, why would we implant a third electrode? So if your hypothesis might say that epilepsy is coming from other sites, and other sites might have been active either on your scalp EEG or on your invasive recordings. It often makes sense to implant the electrode at the same time of the others, because if you need to switch the electrodes, you just need to open up the back part of that incision and you can basically swap them out. So sometimes the planning, or I should say often the planning of these surgeries involves consideration for even much further down the road. And so the point I'm trying to make from the case I just showed you, these were the texts that were given to my epileptologist when I was still in Michigan, this still being that first patient. Um, what was interesting is that both he and his wife were texting my epileptologist over time, being like, "Oh, we think he's having a seizure," and the data would go to us and like, "Yep, he's having a seizure," but we'd also found out how many other seizures they were not recognizing. And even though he was not diabetic, the family actually thought that he was having all these little hypoglycemic episodes. He had so many, in fact, that he was having up to 100 seizures per day that he was not recognizing. And that's kind of the interesting, again, long-term recording that you can do with these devices. And basically, what this eventually led to, as I mentioned, was a surgery. We took out his temporal lobe. We kept the electrodes on the opposite side, and since then, he's actually been seizure-free. So there's a lot of interesting decision making that goes beyond, is this patient purely a surgery candidate or is this patient a neuromodulation candidate? They often come together, and some of that information may change over time. Similar slide to what I showed you earlier in terms of evidence. Everything has to be based on that RCT, that randomized controlled trial, and they're followed up by open label extensions. And you're seeing a very similar mean seizure reduction, about 75% up to 7 years. And some of these patients are actually seizure free. And again, it depends on the type of epilepsy, but often when we're talking about palliative, we were talking about palliative, you can sometimes talk about seizure freedom in these patients if they're appropriately selected and implanted. So a lot of the risks of RNS surgery are very similar to DBS. In fact, they're almost the same. The bigger one being is that because we're putting this device into the skull, patients may have a bit more discomfort at the up front. That will go away over time. A common question is, hey, you're putting a battery in my skull. Does it pooch out? Is it visible? Can I feel it? Because we take that part of the skull out, it actually fits the groove rather well. It's not something that's visible to people. If you do have hair, it's in the hairline, typically in the back part of the skull. If you put your hand over it, yeah, you can feel it if you press down, but it's not something that's going to be intrusive. It's certainly not something that's going to be noticed in your daily life. It is strong, meaning you can, I don't want you to, but you can take a direct blow to it and it'll work just fine, because the clamp that actually holds it in is just as strong as the skull. But otherwise, the adverse reactions are pretty much the same. I do say this is a more complicated surgery than DBS, um, probably just a little bit in terms of the implantation and the planning. But again, it's something that we're very familiar with. Now, way back at the beginning of my talk, I talked about pediatrics. And I said VNS is the only device that has labeling for pediatrics. Um, there's despite that, there is a lot of off-label use of these devices in pediatrics, also for different types of epilepsies, which they're technically not designed for. There is a very, very rich base of literature, meaning there have been studies up the wazoo about pediatric implantation. And these can be case reports, which is a case of one. They can be cases of 10, 20, up to 100, if not hundreds, over multiple institutions. The point being is that there's a lot of evidence to support the use of these devices in pediatrics. They've just never been done in a randomized control fashion. And here's a whole list of studies that show you how many different pediatric studies have been run. Now, RNS, they are running studies at this moment to look at different indications in pediatrics. So the one at the bottom is for pediatrics up to the age of 12. And then the top is LGS or Lennox-Gastaut, a type of generalized epilepsy. So this would be great to be able to expand the indications, which helps with coverage. and also to expand our understanding and the evidence. So more indications are always better. So what do we see for the future? Um, DBS, like I told you, targets something called the thalamus, something called the anterior thalamic nucleus. But there's other parts of the thalamus that we often target. One of the ones you may have heard come up either in casual conversation with other patients with epilepsy or through your own research is something called the central median nucleus. That's something that's been studied since the 80s, if not before. And we've done deep brain stimulation for years. But now it's kind of coming to the forefront again. There is another national study going on that's industry sponsored right now, looking at central median RNS in patients with what we call idiopathic generalized epilepsies. So patients that have generalized epilepsy and can include absence seizures and myoclonic seizures, oftentimes these patients are candidates for anything beyond medical management. And many years ago, VNS might have been the kind of the baseline, the thing to try in everybody. But now we're having pretty good evidence that targeting this part of the thalamus with RNS and with DBS can be very helpful. I can tell you in anecdotal experience um, between Michigan and here, I've done about 30 patients with it, and the seizure average seizure reduction in patients with IGE specifically, that idiopathic generalized epilepsy, is north of 80%. And the randomized control study right now, their 18-month data showed 80 or up just below 80% seizure reduction as well. So these are important numbers and important studies that will become important basically as we go along. And then an always interesting question too is, well, can we actually use these together? Um, there's been burgeoning case series. People have been publishing patients up to 10 patients at a time, where they're talking about patients who have maxed out on vagal nerve stimulation or maybe not ever responded to vagal nerve stimulation, and they're adding things like deep brain stimulation or responsive neurostimulation. This is very in its infancy. It's hard to kind of give a clear answer. I can tell you I've probably done this about 5 times. This is actually my first patient I ever did on, which was an 11-year-old while I was still in Michigan. That kind of wacky S-shaped incision there, that's a corpus callosum that was done years prior. And they have a vagal nerve stimulator. And so we added this ANT DBS, and we found a synergistic, another step for seizure reduction that was above the VNS. And when we're looking at papers that have been published with combining neuromodulation modalities, that's kind of what we're finding. We're adding a different step that acts in synergy to what patients have. And so it makes sense because we're targeting different parts of that network. We're targeting a different mechanism for generating epilepsy. Um, but full disclosure is that, again, this is early work. It'll be interesting to see where this goes, but we don't have anything near a randomized controlled trial to tell us who are the best patients for this um, and how they would respond. And so that's important in my practice, and for any of you considering looking at any neuromodulation device, is when you talk about off-label applications, you have to talk about what is the actual data behind this? There's the risk of the procedure, which is very well known, very well understood. But what's the actual risk to what if I don't really get any better putting this device in? Well, I've gone through this surgery for nothing. And I'd like to think that we do a very thorough workup, and that most epilepsy centers do. But there are still some unknowns, and we have to be honest with our patients, be like, you know what? This is our experience. This is what's been described. But without the benefit of having had randomized controlled trials, we still don't have the rigorous data that might tell us exactly who the right patient might be. So, general overview, general summary right here: VNS, RNS, DBS. Um, when we talk about who are the best patients, VNS, it's on label for focal, but we use it for generalized, unlocalizable, or multifocal. In the past, I would say VNS was probably just kind of, if you weren't a surgical candidate, you were a VNS candidate. We're rethinking that. RNS is up to 2 seizure foci, typically in those eloquent or unresectable areas. The newer research is in those generalized epilepsy. And then DBS, again, is on label for focal, but we're using it for generalized epilepsies as well. There are very specific side effects and complications. The VNS being kind of the throat tightness, the cough, the hoarseness. RNS and DBS, when you jack up the current too much, it might be that tingling, those paresthesias. Any device we ever implant is always a risk of infection. The risk is low, especially when you've appropriately selected your patients. I tell my patients typically it's 1% or less. Battery life is an important one. Vagal nerve stimulators, it's about 3 to 5 years, as are DBS. So what's a battery replacement look like? It's actually very straightforward. The big surgery is having to have those electrodes placed. The battery pocket is open for the replacement. We disconnect the electrodes. We put the new battery in. We set it to the same previous settings. We close up. Battery change takes honestly 20 to 30 minutes. Biggest risk again is infection, but it's something that's very common. Not the infection, the replacement. And then RNS, they will say it's about 10 to 11 years. It's probably on the order of 7 to 10 years. Um, Often it's not having to open that same, sorry, not the entirety of the same incision. The way we implant batteries in the skull is we think hard about where we can open it to kind of pop the battery out, switch the electrodes, and then put the new battery in. But that's something that doesn't still doesn't take too long and doesn't have to be done too often. And then very important questions for MRI compatibility. Um, every device we implant these days, almost every device has MRI compatibility. We need that because obviously patients with epilepsy continue to have investigations throughout the years. Um, you may need an MRI for another indication, and you'll notice that it's compatibility. That's an important distinction. And so these depend on certain scanners, certain field strengths. That 1.5 or 3T is the field strength. And that can be at specific scanners. So downtown we have two 3T MRIs. Some places have experimental 7T MRIs. Most commonly is that 1.5. But they do have to have the right protocol to be able to do imaging with your device. VNS has the most limitations in terms of what we call an exclusion zone. There are certain areas, and those that C and L and T are talking about the cervical, thoracic, and lumbar spine. So basically, there are certain areas of your body that you can't have imaged with a VNS in there. So it's important to know the limitations with MRI, what sort of imaging you have, but you can have an MRI. You can have an MRI. You just have to go to the right institution, and you could talk about that with again your care provider. They'll know that. So just to end off with this again, this is a very basic but still very pertinent decision algorithm, just showing you that yes, there are many ways you can get to neuromodulation and only very specific ways you can get to surgery. And it'll be interesting to see how this continues to advance and develop over the years. So, in conclusion, neuromodulation is a very reasonable treatment option for drug-resistant epilepsy when we can't do resection or ablation. There are three devices. That's vagal nerve stimulation, deep brain stimulation, and responsive neurostimulation. We have great data, and we have great data for which patients will do well. And there's interesting applications like RNS with closed loop technology looking at long-term data gathering. Um, and then the patients that would benefit best are those with seizures that originate from eloquent cortex, multiple parts of their brain, and right now, burgeoning evidence for people with generalized epilepsies. And that is the end of my talk. And I'm happy to take any
Um,
questions.
that's, I am looking for any questions in the chat box. And I actually, Dr. Stout, I did have a question. With the battery life, is it with the VNS specifically, is it more that the more seizures, does it run the battery life down? So if someone is having repeated seizures, does that run the battery down quicker, or is it
So it's yes and no. It's not the repeated seizures that's running the battery low.
okay?
That's the how high is the current being programmed.
Okay.
Um, So patients that have more difficult to control epilepsies tend to have higher energy needs, and those patients will have a shortened battery life. And I'll be
Okay.
honest, it's not atypical for people that have fairly high energy needs to need a battery replacement every almost like 2 years, 2 or 3 years. 3 to 5 years is kind of the average, but yeah, as you go up higher, it shortens the battery life.
So is there a point where I guess they max out on a battery, or is it just that they're just going to continue to go through the batteries quicker? I guess would be the question.
No, that is a good question, and yeah, they kind of reach. I mean, the worst I've seen is people coming in a year and a half for a battery change. But there is a plateau in terms of how much current somebody can tolerate versus the efficacy that's actually given.
And that's it. I'm asking just specifically. I had a client when I was at a county board, and he was young, but he had the VNS, but literally they were having to swipe him. They got to the point where they ended up doing the brain surgery. And I think he was 21 or 22, because it did get to the point that the battery replacement, the frequency of it, it outweighed. So they opted to go with, I believe it was at Children's Hospital. But yeah, I was just curious if that, um,
Well,
if there's,
that's an interesting point because people have talked about reevaluating patients with vagal nerve stimulators.
okay,
We don't often refer to it as like a treatment failure, but it's like after all this time, is there a role for reevaluating if a patient's a surgical candidate in a different way? And I
okay,
would say that would be one indication, absolutely.
okay. Thank you for answering that.
Mhm.
Any other questions? I
We
do
do have
see
some
in the,
questions in the chat.
so this is from Tanya. If a
Mhm.
patient has warning seizures, like an aura, just lost it here. Sorry. I don't know
Oh,
where it went.
chat, I have the chat open here. Let's see.
Got
If
the
a patient
chat
has
correct.
warning seizures, like an oral focal seizure, almost always prior to having generalized seizures, sometimes a smaller seizure could return to generalized. Would this be an option? Also, be time to remain medication, or in time would meds be able to be decreased? So the warning seizure being the focal seizure prior to generalization, um, would this be an option? Yes, yeah. So again, it depends where the focal seizure begins. And the question is, can you localize it in a way that can be treated? And so can you treat it something focal with resection or ablation? And if you can't, then yeah, you can target it if it's eloquence, something like RNS, if you know where it's coming from, and theoretically that will stop the propagation. So it works for both generalized seizures, generalized epilepsies, and that's kind of the more developing evidence. But the best evidence are for people that have that focal onset that then generalizes. And then in time when medications be able to be decreased. It depends. Absolutely, we do see some patients be able to decrease their medication burden. I wouldn't say patients typically come off their medications because again, these are considered palliative devices, so they work in conjunction um, with a medication regimen. But I do know how burdensome medications can be if you're on multiple and higher doses that have side effects. So often it's trying to find that balance where you reach the efficacy threshold with a device, and you're still being kind of carried by your medications. So they often work synergistically. And so there's another question. Is there a way to place the VNS during surgery so it doesn't affect the voice box much? Or does anything connected to the vagus nerve affect the voice box? It's the proximity of the electrode to the vagus nerve. Unfortunately, there's not really much to avoid it in that area. Um, and so again, kind of what I was alluding to earlier, it's stimulation induced. So theoretically, if you reduce the stimulation, you reduce that hoarseness. Patients most often complain about it when they get when it's going off too often or too strong, and you can change both the frequency and the strength of it. But unfortunately, it's a where where it's implanted. It's right next to it, so that's just an unfortunate reality. If a patient has an autoimmune disease, would that be a contraindication? No. We always want to mitigate surgical risk. And so the question is things like, in general terms, things like blood thinners, immunosuppressants. Those are things we have to look at in conjunction with primary care or specialty physicians if they can be held for surgery. Certain immunosuppressants need to be held at the time just to make sure that you lower the risk of developing an infection. But autoimmune disease by itself is not a contraindication for the implantation of any device or for surgery in general.
Okay. Any other questions?
For example, if I was an opera singer, which I'm not, is there a way to turn it off? Yeah, you can turn it down. Yes, you can turn it off completely. Absolutely.
Okay, well, thank you. That was a wonderful presentation. And then if there is no other questions, thank you again for our speaker sponsors, SK Life Science and Akron Children's Hospital. We will be sending out a brief email survey after the conclusion of this webinar, so keep an eye out for that. If you would like a certificate of completion emailed to you, let us know. And again, just some upcoming events. This is the second webinar of the year, so make sure to look at the other ones available on our website. Our past ones are on YouTube. Our next one will be held on September 8th from noon to 1 p.m. And topic is going to be brain health and epilepsy. Dr. Annie Reyes. Also, October 6th will be our last one of the year. That is going to be Sleep and Epilepsy, presented by Dr. Fodor from University Hospitals. And again, all our past seminars are listed on YouTube. Our next in-person event is the annual epilepsy golf outing. That is going to be held on Monday, June 22nd. And then our Outrace Epilepsy Run and Walk at the Cleveland Zoo. That one is a blast. So hopefully you can join us on Sunday, August 16th. Again, thank you for everyone attending the seminar, and we hope to see you at future webinars and events. Thank you again, Dr. Stout, for your presentation. It was great, and thank you for answering our questions.
Thank you for your time and the invitation.